Assalamualaikum, it's me again, Nur Adila Syeda. So today in this video, I would like to talk about the spinal anesthesia. An alternative to a general anesthesia is a spinal anesthetic. A spinal anesthetic can be used for most operations below the waist. So, first of all, in terms of talking about the spinal anesthesia, it is very important to understand the anatomy of the spinal cord. Spinal canals consist of spinal cord with its meninges, fatty tissue, and venous plexus. Meninges are composed of three layers: pia mater, arachnoid mater, and dura mater. CSF fluids contained between the dura and arachnoid maters. The spinal cord usually ends at the level of L2 in adults and L3 in children. Dural puncture above this level is associated with a slight risk of damaging the spinal cord and is best avoided. Spinal anesthesia is indicated to provide anesthesia for procedures involving lower limbs, perineum, pelvic, and lower abdomen. Spinal anesthesia is best reserved for operations below the umbilicus, for example, hernia repairs, gynecological and urological operations, and any operation on the perineum or genitalia. All operations on the leg are possible, but an amputation, though painless, may be an unpleasant experience for an awake patient. It is ideal for patients who is having cardiac disease, liver disease, renal failure, and also used in obstetric anesthesia. Spinal anesthesia is especially indicated for older patients and those with systemic disease such as chronic respiratory disease, hepatic, renal, and endocrine disorders such as diabetes. Most patients with mild cardiac disease benefit from the vasodilation that accompanies spinal anesthesia, except those with stenotic valvular disease or uncontrolled hypertension. It is suitable for managing patients with trauma if they have been adequately resuscitated and are not hypervolemic. In obstetrics, it is ideal for manual removal of retained placenta. There are definite advantages for both mother and baby in using spinal anesthesia for a cesarean section. Most of the contraindications to spinal anesthesia apply equally to other forms of regional anesthesia. These include inadequate resuscitative drugs and equipment. No regional anesthetic technique should be attempted if drugs and equipment for resuscitation. Next is clotting disorders. If bleeding occurs into the epidural space because an epidural vein has been punctured by the spinal needle, a hematoma could form and compress the spinal cord. Patients with low platelet count or receiving anticoagulant drugs such as heparin or warfarin are at risk. Other contraindication is hypovolemia from whatever cause, for example bleeding, dehydration due to vomiting, diarrhea, or bowel obstruction. Patients must be adequately rehydrated or resuscitated before spinal anesthesia or they will become very hypotensive. Next is patient refusal. Patients may be understandably apprehensive and initially state a preference for general anesthesia. But if the advantages of spinal anesthesia are explained, they may then agree to the procedure and be pleasantly surprised at the outcome. If despite adequate explanation, the patient still refuses spinal anesthesia, their wishes should be respected. Next is uncooperative patients. Likewise, mentally handicapped patients and those with psychiatric problems need careful pre-operative assessment. Septicemia. Due to the presence of infection in the blood, there is a possibility of such patient developing meningitis if a hematoma forms at the site of lumbar puncture and becomes infected. So, how is spinal anesthetic given? The spinal anesthetic will be performed in the anesthetic room or in the theatre. Local anesthetic solution injected into the subarachnoid space blocks conduction of impulses along all nerves with which it comes in contact, although some nerves are more easily blocked than others. There are three classes of nerve: motor, sensory, and autonomic. The motor convey message for muscle to contract, and when they are blocked, muscle paralysis results. Sensory nerves transmit sensations such as touch and pain to the spinal cord and from there to the brain, whilst autonomic nerves control the calibre of blood vessels, heart rate, gut contraction, and other functions not under conscious control. Generally, autonomic and pain fibers are blocked first and motor fibers last. This has several important consequences. For example, vasodilation and a drop in blood pressure may occur when the autonomic fibers are blocked and the patient may be aware of touch and yet feel no pain when surgery starts. The patient should be well hydrated before the local anesthetic is injected and should have an intravenous infusion in place so that further fluids or vasoconstrictors can be given if hypotension occurs. Spinal is also known as neurological anesthesia and proved to be extremely safe and managed well. There are 3 positions for spinal anesthesia. First is sitting position. Second, lateral decubitus position. Third, prone position. Most often, the spinal anesthetic will be done whilst you are awake. Your anesthetist will instruct you as to what position you need to get into for the procedure to be done. This will be in 1 or 2 positions. In a sitting position, with you slump forward, chin on your chest, shoulders down and bottom curl under. These positions help to open up the spaces between the bones in your back, which is where the anesthetist needs to put the spinal anesthetic. Once you are in the correct position, your back will be cleaned with antiseptic. The anesthetist will scrub their hand and put on a surgical gown, gloves, hat and mask. These steps help to minimize the risk of infection. The anesthetist will feel your back quite firmly to identify certain landmarks and identify where exactly the spinal anesthetic needs to be. Then, the fine spinal needle will be inserted. At this point, it is particularly important to keep very still. You should not feel significant pain. However, if the needle goes close to one of the nerves that supply your legs, you may feel a shooting pain down one of your legs. Once the medication has been injected, you will feel a warm tingling sensation in your bottom and your legs start to go numb. The spinal anesthetic doesn't work instantly. It takes a little time to work, approximately 5 to 15 minutes. Local anesthetic agents are either heavier, hyperbaric, lighter, hyperbaric, or have the same specific gravity, isobaric, as the cerebrospinal fluid. Hyperbaric solutions tend to spread below the level of the injection, while isobaric solutions are not influenced in this way. It is easier to predict the spread of spinal anesthesia when using a hyperbaric agent. Isobaric preparations may be made hyperbaric by the addition of dextrose. Bupivacaine 0.5% hyperbaric heavy bupivacaine is the best agent to use if it is available. 0.5% plain bupivacaine is also popular. Bupivacaine lasts longer than most other spinal anesthetics, usually 2 to 3 hours. Lignocaine. Best results are obtained with 5% hyperbaric lignocaine, which lasts 45 to 90 minutes. 2% lignocaine can also be used, but it has a much shorter duration of action. If 0.2 ml of adrenaline 1/2000 is added to the lignocaine, it will usefully prolong its duration of action. Lignocaine from multi-dose vial should not be used for intrathecal injection as it contains potentially harmful preservative. Then, how do they test the block? Your anesthetist will need to check the quality and level of the block. In order to do this, you will be asked if you can lift your legs off the bed. They should feel very heavy or you may not be able to move them at all. The anesthetist may then use ice or alcohol swab to check the level of the block. When the spinal anesthetic is working well, you will not be able to feel the cold. Your anesthetist may also check the block using a pinprick or gentle touch. Once the anesthetist is happy that your spinal anesthetic is ready, your operation can start. Some people are afraid that they are going to see or hear things during the operation. During the surgery, we put up a surgical drape so that you do not see anything during the procedure. And also, some of them will give you sedation medication during the surgery. You will receive your spinal anesthesia when you are awake, so that you can communicate with your anesthetist if you feel any discomfort during the procedure. So, what are the advantages of the spinal anesthetic? Cost. Anesthetic drugs and gases are costly and the latter often difficult to transport. The costs associated with spinal anesthesia are minimal. Patient satisfaction. If a spinal anesthetic and the ensuing surgery are performed skillfully, the majority of patients are very happy with the technique and appreciate the rapid recovery and absence of the side effects. Spinal anesthesia produces few adverse effects on the respiratory system as long as endally high blocks are avoided. As control of the airway is not compromised, there is a reduced risk of airway obstruction or the aspiration of gastric contents. This advantage may be lost with too much sedation. There is little risk of unrecognized hypoglycemia in a awake patient. Diabetic patients can usually return to their normal food and insulin regime soon after surgery, as there is less sedation, nausea, and vomiting. Spinal anesthesia provides excellent muscle relaxation for lower abdominal and lower limb surgery. Blood loss during operation is less than when the same operation is done under general anesthesia. This is as a result of a decreased blood pressure and heart rate and improved venous drainage, which results in less oozing. Splenic blood flow. Because its effects on increasing blood flow to the gut, spinal anesthesia reduces the incidence of anastomtic dehiscence. Visceral tone. The bowel is contracted by spinal anesthesia and sphincters relax, although peristalsis continues. Normal gut function rapidly returns following surgery. Coagulation. Post-operative deep vein thrombosis and pulmonary emboli are less common following spinal anesthesia. Then, what is the disadvantages of spinal anesthesia? When an anesthetist is learning a new technique, it will take longer to perform than when he is more practiced, and it would be wise to let the surgeon know that indications of anesthesia may be longer than usual. Once competent, however, spinal anesthesia can be very swiftly performed. Occasionally, it is impossible to locate the dural space and obtain cerebrospinal fluid, and the technique has to be abandoned. Hypotension may occur with higher blocks, and the anesthetist must know how to manage this situation with the necessary resuscitative drugs and equipment immediately to hand. As with general anesthesia, continuous close monitoring of the patient is mandatory. Some patients are not psychologically suited to be awake, even if sedated during an operation. They should be identified during the pre-operative assessment. Even if a long-acting local anesthetic is used, a spinal is not suitable for surgery lasting longer than approximately 2 hours. If an operation unexpectedly lasts longer than this, it may be necessary to convert to a general anesthetic. There is a theoretical risk of introducing infection into the subarachnoid space and causing meningitis. This should never happen if equipment is sterilized properly and an aseptic technique is used. A posterior headache may occur post-operatively. This should be rare. Then, what are the side effects and complications of spinal anesthetic? So these are the complications that may occur from the spinal anesthesia. Some of the medicines that are put in the spinal anesthetic can make you itch. You might find that you find it difficult to pass urine. This happens especially in men. If this happens, you might need a urinary catheter until the spinal anesthetic has worn off completely and your bladder function returns to normal. You might get a particularly bad headache that is caused by the spinal anesthetic. This happens in 1 in 200 to 1 in 300 spinal anesthetics given for young women giving birth, but it is much less likely in an older person. This headache feels different to normal headaches in that it gets worse when you sit or stand up and better when you lie down. Normally, this type of headache resolves with rest, drinking plenty of fluids, and taking simple painkillers such as paracetamol. The spinal anesthetic can cause your blood pressure to drop. If this happens, your anesthetist will give fluid into your drip and medicines to increase your blood pressure such as vasopressors. Some of the patients may get nausea and vomiting, most commonly due to hypotension. To treat this side effect, we must give patient oxygen, correct the hypotension, and give antiemetics. Very occasionally, the spinal anesthetic can affect higher up the body than is needed for the operation. In this situation, you may experience weakness of your arms and, in very rare situations, difficulty in breathing. Next is nerve damage. This is the complication that patients understandably worry most about. The risk of permanent nerve damage is extremely rare, about 1 in 50,000. The risk of temporary loss of sensation, pins and needles, and sometimes muscle weakness is higher but usually resolves in a few days to weeks. So, from this video, we know that spinal anesthesia is a safe and effective form of anesthesia which can be used as an alternative to general anesthesia, commonly in surgeries involving the lower extremities. So that's it. Thanks for watching. Assalamualaikum and bye-bye.